Oh, that's fantastic. Can you all hear me and see me? Hopefully. Sorry for the camera position. Probably it's going to be a little bit weird on Zoom, but I hope all of you can also see the slides.
Yeah, that's fine. That's fine.
Okay. Okay, so I think we have every member of the committee here.
All right, so most of you probably know the drill. Yeah, Rogerio will do his presentation about 40, 50 minutes. Take questions from the public. We'll ask anybody who's not on the committee to step out. Committee will spend some time with Rogerio. We'll ask Rogerio to step out, and then we'll make a decision. But before we get going, your advisor, Dr. Liederman, can introduce you and your project.
Thanks. So, those of you who heard Rogerio speak before may have guessed that he's not a native of Chicago. I'm just from Brazil and did his undergraduate studies there in bioengineering. And then we were very fortunate that he came here and joined us at UIC, initially for a master's degree in bio-E. Most of that work was performed with Professor Christian Luciano, who we have here virtually, as well as myself, in terms of beginning some of his work in establishing a framework for applying the tools of artificial intelligence in surgical guidance. Rob received his master's degree in 2020, I think, when his defense was, and then again, we were very fortunate that he decided to stay on to pursue a PhD in bio-E. So just before you get started, Raj, I do want to say that Rogerio has really been an incredibly talented student. He's also been very, very independent. We had a transition in the lab. Christian Luciano left. We were very, very fortunate that Dr. Gargani joined the Department of Ophthalmology as well. And so Rogerio has benefited a great deal from his technical expertise, from a number of the other committee members as well. So I want to thank all of you here for supporting him in his intellectual development, in his research and his progress. And we're very excited to hear his talk today.
Thank you. Thank you, Dr. Liederman. Okay, so I should get going. I'll just... All right. Again, thank you, Dr. Liederman, for the introduction. I'm here to defend my PhD, and the title of my dissertation is Intraoperative Artificial Intelligence and Surgical Data Science in Ophthalmology. And the work you see here today, this is just the outline. We'll be talking a little bit about surgical education in vitreoretinal surgery, also the current scenario of AI in ophthalmology and surgery. Then I'll be presenting my graduate work. We'll talk a little bit about future steps, and then we'll have the public and private Q&A. So just to set the stage, vitreoretinal microsurgery, that's what we'll be talking here about. It's a surgical procedure to restore, preserve, and improve vision, and it treats a range of conditions, such as diabetic retinopathy, macular holes, and retinal detachments and tears. But in order to do so, the vitreoretinal surgeon needs to remove the vitreous, this jelly material here, to get access to the retina and then deliver the treatment. But we are talking about the eye, so the surgeon is always working in a delicate and limited operational space, also with micro-scale instruments and targets, and of course, non-ideal lighting conditions. Now let's talk about surgical training in vitreoretinal surgery. As today, as most of surgical procedures, a trainee is supervised by a faculty surgeon. And this is all under work hours restrictions. And these traditional training evaluation methods, they are limited. They're time consuming, and there are no established quantitative, objective, or standardized metrics or evaluation methods. And this leads to an unstructured and non-validated surgical assessment of skills. At the same time, there has been some efforts in trying to establish surgical assessment in vitreoretinal surgery and also in other ophthalmic procedures. such as the development of a rubric system in which the surgeon gives a score to the trainee according to its advancement during the program. Although the surgical community didn't adopt it as much, probably because surgeons, they don't have much time to just give grades to novice surgeons. And moreover, surgical training nowadays is also prone to bias. So there are studies showing that, for example, women usually score lower than their male peers in standardized tests, self-assessments, and also assessment by the attending surgeons. And a similar condition happens with minority populations in medical school. So how can we evaluate vitreoretinal surgeons in an objective and unbiased manner? So in the past few years, we've been seeing the rise of AI in ophthalmology, such as using neural networks to detect lesions and recognizing disease. Also, some computer vision algorithms that can monitor the progression of retinal diseases, and even the development of real-time surgical guidance based on AI that can provide feedback to the surgeon and help the surgeon during the decision-making process. At the same time, we've been seeing the rise of a field called surgical data science. And surgical data science can be defined, can be based on three main blocks. The first one, we call it perception. And perception is basically the data we can acquire from the operating room, from the OR, such as the sensors attached to the patient, the patient records, and the factors, which are basically the surgeon or the instruments that are being used by the surgeon. Then we have interpretation. And interpretation is basically how we are processing this data and interpreting this data. What meaningful information we are getting from it. And finally, we have the assistance block. And the assistance block is how we deliver this information to the surgeon or to the staff in the OR. And this could be delivering the therapy per se, or the diagnosis in real time, or even helping in data-driven surgical training. Some examples of surgical data science and all that is coming out from it is like the detection of intraoperative events, predictions of intraoperative complications in real time, and even data-driven models for surgical assessment and training. But we are talking about data. But in vitreoretinal surgery, and in surgery in general, what kind of data we can consider? So we know that instrument maneuvers are representative of skills during surgery. So in previous research, for previous studies, compared to fellows attendings, they tend to peel the membrane during vitreoretinal surgery faster and more efficiently, leading to lower attempts and lower time executing this task. And the previous studies were also able to classify surgeons just by the size, centrality, and the way they're performing a specific surgical maneuver. Now,
sorry for the interruption, Rogerio. Could you share your screen so that we can see your presentation?
I've checked in the beginning of the presentation. I'd like to check with everyone if everyone is being able to see my screen.
I think we see on your camera,
cannot.
but the
can't see
background
the
is
screen.
right. The background is blurred, so we cannot see that either.
Okay, let me check again. So,
all right, thank you.
Can you all see it now? The main screen?
Yes, thank you.
Yes,
Perfect.
thanks.
Thank you so
I'm
much.
so sorry. Yeah, that's good. So, as I was saying, instrument maneuvers are representative of skills during surgery. And there's also another data modality that we can consider during surgery. And I want to talk a little bit about areas of visual attention or gaze behavior or eye movement studies, eye tracking, and so on. So imagine a user accessing a website and then paying attention in a specific area of this website. This might indicate that this area contains some content that it's of the interest of the user. Now imagine when we are comparing an experienced driver with a novice driver. So an experienced driver might tend to have the behavior of looking at the road, focusing on the road, while a novice driver tends to pay attention to the dashboard and the speedometer, right? And this might indicate a lack of confidence of a novice driver and so on. So we can also do the same during surgery. So it has been proven that areas of visualization, gaze behavior can distinguish experts from novice in the medical field. So, for example, in this study, glaucoma specialists were invited to analyze some fundus photographs to diagnose glaucoma. And it was observed that experienced clinicians, they have a more systematic way of looking for the disease. And this leads to faster diagnosis. And it has also been proven that if we ask a novice surgeon, a novice specialist, sorry, to just follow the steps or the gaze patterns to learn from the gaze patterns of an experienced clinician, they can improve their skills when diagnosing glaucoma. So with all of this being said, the main hypothesis here is that there are differences in instrumentation handling and visual attention among subgroups of vitreoretinal surgeons. And if we can identify and measure these divergences, we should be able to enable data-driven metrics to quantify surgical training and hopefully to improve outcomes of surgical training. So a year ago, I've shown you these three main aims for my research proposal. The first aim was to identify instrumentation maneuvers, anatomic elements, and the gaze of the surgeon. The second aim was to investigate some metrics that could quantify surgical behavior. And finally, to identify metrics related to the gaze behavior of the surgeon. These three aims led to these four main projects that I'm going to show you here today. And these are the four chapters of my dissertation. And these are also related to four papers. So some published, some about to be published. So I'd like to start with semantic understanding of vitreoretinal surgery, which is based on aim 1, but we will also be talking about OPIs, objective performance indicators, based on aim 2, the assessment of surgeons' area of visual attention and its metrics, covering aim 1 and 3. And finally, we want to automate the assessment of surgeons using these two data modalities, which is also related to aim 3. So starting with aim 1, so when we talk about self-driving car, for example, we know that the car and the system is basically identifying everything that's happening in front of it. So every pedestrian, every car running around, every stop sign, and so on. The system is recording all this data and making decisions based on this data. So what if we can do the same, but in vitreoretinal surgery? So what if we can identify every single instrument and every single anatomic element in real time or post hoc? And we can record all this data in a database, so we can investigate surgeons' maneuvers and surgeons' behavior. So that's what we did here. We acquired over 100 cases from UI Hospital, containing 3 selected surgical phases, most of them corvotrectomy, which is basically, again, removing the vitreous to get access to the retina. Membrane peeling, just removing unwanted tissue from the retina. Endolaser photocoagulation, which is a surgical step mainly used to treat retinal detachment or retinal tears. Then we asked novice surgeons, or again, fellows or residents, to annotate these frames, over 600 frames based on these videos. And they basically annotated the area of each instrument and also of every anatomic element. Then we fed this instant segmentation neural network, and I'll just go straight to the output of the network, but we can discuss it further if we have time. This neural network was outputting the spatial position and the area of every single element being tracked. Again, instruments and also anatomic elements. And these were the results we functioned based on this work. So we were able to reach values over 90% for area under procedural call curve. And we were also able to reach real-time performance, as you can see here in this video. And we can attach this platform to any surgical microscope, and we can acquire all this data for every single case regarding every single instrumentation maneuver during the procedure. And just some quick notes on this first part. Again, instant segmentation neural networks, they can provide real-time and post-hoc identification of multiple features in surgery. And we are using this as a data harvest platform. So for our surgical data science projects. Compatibility, expandability, it's compatible with multiple visualization systems, and we can also provide feedback to the surgeon in real time if desired, such as like undesired collisions between the instrument and some delicate tissues. The challenge here, the model is limited to data and the devices in which the system was trained, and no real world reference for some units. So it's hard to tell if the instrument is moving like 1 centimeter or 2 centimeters, since the surgeon might be always changing the zoom level of the camera. Now going to the second part, objective performance indicators. So here on OPIs, we want to investigate metrics that might be able to indicate the level of experience of a surgeon. So there has some research in some other surgical fields, mainly robot-assisted surgery, that tries to identify these metrics that can quantify surgical efficiency, or it can distinguish surgeons from different backgrounds. For example, some overall metrics, such as the total completion time of a task, or the total idle time where no instrument is being moved during the procedure. Some other instrumentation metrics, such as the path length of a surgical instrument, the moving time, the velocity of the instrument tooltip, and so on. And also even some camera metrics, how many times a surgeon moves the camera, zooms in, zooms out, and the moving time of the camera. So since we have a platform that can extract all the spatial data, but for vitreoretinal surgery, can we identify metrics that are similar to this, but to reflect the experience of surgeons in this field? So to answer this question, we acquired, again, over 100 cases, but now we acquired these cases from 2 surgical sites. A few cases here from UIC and a few cases from another surgical site in Mexico City, because we wanted to expand the demographics of our database to see if these metrics would be applicable in another hospital. And then we classified all these cases between with the level of experience of who was performing it. So we had fellows in their first year of training, and we identified them here as F1s. We had fellows in their second year of training as F2s. We had attendings with less than 5 years of experience, and we call those A1s. And we had attendings with over 5 years of experience, and we call these A2. So we got all these 100 surgical cases from 22 participants, and some of these cases were recorded, like they are dated back 2015. And we fed the same instant segmentation neural network we developed in the first project. So what we did is that for every single frame, we are able to extract the spatial position of every single element on screen, the instrument, and also anatomic elements. And then we can register all of these in a database. So we now have every single instrument maneuver and also every single interaction of the surgeon with the system. But we need to select some metrics to investigate. And we want to check if these metrics can translate the level of experience of a subject. So the surgical metrics we wanted to select as OPIs were surgical phase length. How long does it take for a surgeon to complete a single task? The total idle time as a percentage of the phase length. So let's say during the core vitrectomy, the surgeon didn't move the vitrector for like 10% of the surgical phase. Instrument tooltip, velocity and acceleration. For example, during acceleration, we might be able to identify tremor. Then we have higher levels of acceleration. That the mean distance from instrument tooltip to the optic disc, since the optic disc is a very delicate element in the retina, so we wanted to check if this could be a behavioral, if this behavior could indicate a harmful maneuver. The proportion of time with the optic disc and the fovea in the field of view. So we were hypothesizing that novice surgeons, they tend to keep looking at these elements so they have a reference during the surgery of where they are inside the eye. Number of microscope movements. So every time the camera was moving, all the elements were moving in the same direction at a similar speed. We classified that as a camera movement. And the total travel distance of the instrument tooltip. So basically the total path length, not considering the camera movements. And sorry, we also had the centrality, which is basically the distance of the instrument tooltip to the center of the view of the surgeon. And our hypothesis here is that experienced surgeons, they tend to place the instrument tooltip in the center of the field of view more often. It's kind of a common recommendation among retinal surgeons as a safety precaution, so you know you're focusing on the center of the screen during the procedure. So I know this might look messy right now, but I want to show the potential divergences we identified in the metrics we selected. And here you see that in orange, these are the mean values of the attendings, and in blue, the mean values for the fellows. And we have for each surgical phase being used here: core vitrectomy, membrane peeling, and endolaser photocoagulation. So when we analyze some metrics, you can see that, for example, the surgical phase length among fellows is notoriously higher than with attendings. The same can be said with the total idle time, and also with the proportion of the time with the optic disc in the field of view. So as we hypothesized, fellows, they tend to rely on the optic disc and the fovea in their field of view more often, so they feel confident performing their surgical tasks. Again, the total travel distance is also higher among fellows, although this might be directly related to the surgical phase length. When we talk about centrality, we identified that novice surgeons, they tend to they tend to have the instruments further from the center of the screen, and that could again also indicate that they're not focusing their view on the center of the screen with the instrument there. With the instrument tooltip acceleration, only during membrane peeling, interestingly, we were able to identify higher acceleration values for fellows. And again, this could be an indicator of tremor, or not only tremor, but also like the number of attempts of peeling. So every time a surgeon is trying to peel, there's a peak in acceleration, and this might be translating these sort of conditions. Although without statistical significance, the number of microscope movements were higher among experienced surgeons. And it's interesting because in other surgical fields, it has been proven that experienced surgeons, they tend to move the camera more often, always looking for an optimal visualization of the surgical field of view. Now, here we were grouping all the four groups into two main ones, right? We grouped fellows from year 1 and year 2, and attendees with less and over 5 years of experience. Now here, and I like to call these learning curves, we are keeping the original separation in F1s, F2s, A1s, and A2s. And then you can see the behavior, how their behavior changed over time during their surgical training. And I'd like to start with this initial set of metrics. you can see here that for every single surgical phase for corvatrectomy, membrane peeling, and laser, you can see a decrease, the tendency of decreasing in surgical phase length, total idle time, the proportion of time with the optic disc in the field of view, and the total travel distance of the instrument tooltip, mainly for corvatrectomy. The centrality, again, it's only significant during corvatrectomy. But the interesting thing here is that you can see the biggest drop in values and the biggest discrepancy in behavior between fellows in their second year and attendings with less than 5 years of experience. So we might be able to start taking some conclusions out of this. For example, does attendings during their initial 5 years of experience as attendings, is it like when they get the biggest jump in performance or knowledge during surgery? And what I like observing is exactly like this. Like using this platform, we are able to check in a timeline manner the advancement, the progression of a surgical training program. Now, for other metrics, you see an increasing tendency, such as the distance from instrument tooltip to the optic disc. So an attending surgeon tends to place the instrument tooltip further away from the optic disc, and that might be a good sign of being more aware about potential complications. And again, without statistical significance, but we can also see the trend of like attending surgeons moving the camera more often. So again, the most important point here is that now, from now on, we're able to identify how surgeons are behaving accordingly to their advancement in the program, even after they become attendings. So some conclusions here. These initial set of surgical metrics in vitreoretinal surgery. Nothing like this has been done before. Again, it's a quantifiable assessment. It's a groundwork for future automation for surgical assessment. It works with heterogeneous surgical procedures. When you consider like cataract surgery, we have the same elements. We have the instrument maneuvers, we have the elements, the anatomic elements during cataract, and we should also be able to transfer this platform to that. Of course, we face some challenges here. These metrics are all predefined, so we are not mitigating bias here. We are still asking surgeons about what metrics they think are important and that can translate surgical efficiency and experience. Demographic expansion, we use it 100 cases from 2 different surgical sites, but it's still a low number if you consider the number of cases performed by fellows, residents across the US or across the world. And of course, this is a point that I always like to talk about. When we put out this information, for example, that novice surgeons, they tend to move the instrument, the camera less often. We need to consider how these trainees are receiving a message. We don't want trainees to just start moving the microscope camera and getting a better score and just to be considered an expert, right? Now going to the third project that covers AIM-1 and AIM-3, the investigation of surgeons' areas of visual attention, and we're also talking about some metrics related to visual attention. So as we talked about, eye gaze, areas of visual attention, eye movement, eye tracking, we can identify subgroups of experts and non-experts in different fields, and it's not different with surgery. Some previous research, some previous studies compared the gaze behavior of trainees and experienced surgeons doing laparoscopic surgery, both in real time in the OR and also during surgical simulations. And we wanted to do the same with vitreoretinal surgeons. Now, when we talk about areas of visual attention and gaze tracking, there are some metrics in this field that we can quantify, that we can investigate. And I'm going to show you, this is just a small demonstration of how it works. And I'll be talking about fixations, saccades, dwell time, and travel distance. So imagine that you're here watching a surgical procedure or performing a surgical procedure, and you have your fixation here in the pupil area. So you're focusing there in the pupil, you're watching the pupil, and the time you spend focusing on this element, it's the dwell time. Now, you want to see what's happening around the instrument tooltip, right? So you perform a saccade, and then you have a second fixation in your second area of interest. And then the time you spend here, it's your dwell time in the instrument tooltip area. And the travel distance of your gaze is, of course, depends on the reference you're using it, if you're looking at the screen or a projector, so on. But the travel distance is the measurement of how much your gaze travel through the environment. So in order to perform this proof of concept, we invited 11 subjects between attending physicians, clinical fellows, and residents to watch some surgical procedures, short clips of surgical procedures. So what we wanted to do here was to put the surgeons to watch the surgical procedures in a monitor. And we had a gaze tracking bar, an eye tracker bar, acquiring their gaze position at every single frame of the video. So we did that, we recorded all this data, and I'm going through the details of the surgical cases used here. But for every frame acquired during this gaze study, we had again our instant segmentation neural network identifying every element on the screen, the instruments, anatomic elements, and we also had the gaze coordinates being acquired at the same time. And with this data, when we combine it, we are able to identify surgeons, the surgeon's area of interest, frame by frame, second by second, and also surgeons' gaze patterns, how the surgeons were looking around when watching the surgery. So these were the selected surgical phases during VR surgery. Again, corpotrectomy, membrane peeling, and the laser photocoagulation. And we also decided to add cataract surgical phases, such as capsulorhexis, phacoemulsification, and cortex removal, since we also had cataract physicians and also some comprehensive practice clinicians. And when we start investigating some of these metrics in visual attention, first thing we observed was that attending surgeons, they tend to have a lower overall Cartesian distance travel through the screen when watching the surgical procedure. And again, this might indicate that attendees, they just go straight to the point. So if they're interested in looking at a specific surgical complication or whatever it's happening, attendees, they don't look around, they just go there and they focus on that. Now, since some of these videos had, let me indicate it here. Since some of these videos had basically how these device parameters on screen, so showing like the level of vacuum and the intraoperative pressure inside the eye and so on, we're able to identify, to differentiate how experienced surgeons behave compared to novice surgeons when looking at it. And we observed that residents and fellows, they exhibited more fixations to these device parameters on screen compared to attending surgeons. And this is kind of similar to an experienced driver looking at the dashboard, a novice driver, sorry, looking at the dashboard more often compared to an experienced driver. It could indicate a lack of confidence. So novice surgeons, they need to check the instrument parameters more often, so they're sure that nothing wrong is happening, while attending surgeons, they keep focusing on the instruments and also in the surgical field of view. Now, we were also able to investigate the dwell time. Again, the time spent focusing on a specific element being tracked. And here, although without statistical significance, residents had an increased dwell time with the instrument tooltip location. And when we talk about this, we might indicate that attending surgeons, they tend to scan the peripheral areas during the surgery, looking for potential indications of complications or what you're doing here with the instrument. it might be affecting or not some tissue outside their field of view. And novice surgeons, they tend to keep focusing on the instrument tilted. And again, this can go back to the lack of confidence thing, since novice surgeons, they want to be sure they're not accidentally hitting the retina or performing any dangerous instrument maneuver. And some conclusions here. Again, visual attention metrics, as in other surgical fields, can distinguish surgeons' levels of experience in vitreoretinal surgery and in cataract surgery also. Some limitations we have, of course, this was a proof of concept. It's a controlled environment. We had a limited cohort and from a single surgical center, only from here, from UIC. And the main point here is that we were having surgeons as observers. They were not doing it. They were just watching. Although previous studies showed that actually there's not much difference in gaze behavior when you're doing versus watching. At least in some tasks in which they investigated. When you're doing something, you have faster response times, you have faster saccade velocities and faster fixations, but the behavior is quite similar. So, of course, we need to bring this to the OR so we can be sure that the same happens in ophthalmic microsurgery. But this is a good indicator that these metrics might be reliable. Now, going to the final project. And here, we want to automate the assessment of surgeons' experience, combining these two data modalities, instrument maneuvers and visual attention. So we know that instrument maneuvers are representative of surgeons' skills, and we know that areas of visual attention can also do the same. So what if we can combine this and make something more reliable, more robust for surgeons' experience and evaluation? And so when we talk about automating surgeons' assessment, we need to consider that in the second project, we were asking surgeons to select some surgical metrics, right? But the manual selection of metrics is challenging. And again, not only challenging, it induces bias. You're asking surgeons, what do they think, what metrics they think it would be the ideal ones to represent surgeons' skills. So can we automate it? And then we get rid of all these analysis and we have something simpler and without being subject to bias. So for this another proof of concept, we wanted to work with the IC surgical simulator. This is a platform with standardized tasks that VR surgeons, cataract surgeons use during their training in most of the residency programs in the US. So it's widely available within the US, and it has been proven to enhance training outcomes. So surgeons, they tend to learn faster when performing these tasks with the surgical simulator, with the IC. So what we wanted to do here was to select some surgical tasks available for training in this platform. And again, we selected corvatrectomy, membrane peeling tasks, endolaser photocoagulation, and phaco emulsification pertaining to cataract surgery. And we asked a range of surgeons to perform it. So we asked subjects to perform these 4 tasks. Actually, they were performing around 7 tasks, but they were classified into these 4 main ones. Between attendings, fellows, and residents, all from here, from UIC. And what we asked them was to, when performing a surgical procedure with the IC, instead of looking to the binoculars, to look at this external monitor. So when they look at this external monitor, we have the eye tracking bar, also gathering the gaze data. And then we have our server here. And what we were doing here was that we were acquiring the instrument maneuver. Oh, sorry. Let me just play video. Great. So we were acquiring here the instrument maneuvers and also the gaze position provided by the eye tracking bar, using again the instance segmentation neural network we developed in the first project. So now, since we know that these both data modalities are representative of surgeon skills, we are acquiring them both in real time when a surgeon is performing a task. So what have you done with all this data? So imagine that you have a timeline and you have the X and Y position for every frame of every instrument being used, of every retinal element, and the gaze position of the surgeon, right? So you can see here, you have this nice timeline. What we did was we split this data into several 10-second sliding windows. So for every 10 seconds, we were able to identify what instrument was being used, what maneuver was being performed, and what was the gaze behavior, where the surgeon was looking at during that piece of time. Then we worked with a CNN LSTM neural network. And again, we had 4 convolutional layers, one-dimensional convolutional layers, extracting the most prominent features of these instrument maneuvers here. And let me go back to the laser pointer. Perfect. So we were getting, for every 10 seconds, we were feeding into these 4 layers, and we were getting the most prominent. The network was learning what are the most prominent features. It could be a tremor, it could be a specific maneuver, but that's what the network was learning. Also with the gaze data. And then we also had 2 LSTM layers, long short-term memory layers, and we also did experiments with a single layer. And what these layers do is to indicate the temporal dependency. So let's say you're doing maneuver A first, and then you're going to maneuver B. These layers are able to identify that and link, let's say, the data. And the output of the network was basically a score showing if who was performing during that 10-second window was a resident, a fellow, or an attending surgeon. And now I'm going to show you some models we have trained. I would like you to bring your attention here to 3 main models first. And now we are talking only about tasks related to vitreoretinal surgery. So corvatectomy, membrane peeling, endolaser photocoagulation. We have here our first model that was trained and validated only using instrument maneuvers and gaze behavior of surgeons performing the corvatectomy task. We had a second model trained and validated to classify, again, the level of experience of a surgeon performing membrane peeling. And finally, we had a model that was trained only using the data from endolaser photocoagulation. And every single model of these tried to identify the level of experience of who was performing some specific tasks in corvatectomy, membrane peeling, and endolaser. Now, what we did here is that we retrained each of these models with 3 different combinations of data. And the F1 scores here we are referring to, the first row is related to trying to classify residents as residents. And the second row is trying to classify fellows as fellows. And the last one is trying to classify attendings as attendings. So when we train the model only with the gaze data, only with the eye movement behavior, we are not able to get significant values trying to identify the level of experience of surgeons, right? You can see that the values are really low. Sometimes the model cannot get anything right. We get some zeros here. So gaze-only data is not enough for a model. When we consider maneuvers, instrument maneuvers only data, we see a slight increase in performance here. And you can see that it still does really bad sometimes, but you can still see overall that there's a bump in performance. And then what we can state here is that instrument maneuvers can more prominently displays the behavior of the surgeon performing the procedure. So they're more representative of surgeons' skills compared to areas of visual attention, at least when we consider this model we are training. Now, when we merge these two data modalities, maneuvers and gaze, we get really good performance. So we get really good performance in several scenarios, and I would like to bring your attention here to this model that was trained using curvatrectomy instrument maneuvers and areas of visual attention, validated on the same data, and then tested on the same surgical task. Of course, we separate the data between train validation and test to not mess up with the data distribution, but we were able to get really, really good results. Right? When we put a novice surgeon and an experienced surgeon to perform a curvatrectomy within the IC or a few curvatrectomy tasks, and when we feed our neural network, we were able to distinguish them really well. But it's also interesting that, for example, with the model trained with membrane peeling maneuvers and membrane peeling areas of visual attention, we get really good results even when evaluating surgeons' level of experience across the three surgical phases. And this might indicate that some surgical tasks, some instrument maneuvers, actually the data can be so valuable that the model can learn even how to distinguish surgeons performing a totally different task. So even though we asked surgeons to perform curvatrectomy, we train a model on that. If we ask them again to just perform some membrane peeling, and if we ask them to perform curvatrectomy, that same model can also classify them performing these new tasks. So basically, this could indicate that the knowledge is transferable between models and evaluation tasks. And now, when we add the faculty task, things get a little bit more interesting, I would say, because we have the same behavior. Gaze only doesn't give us good scores at all. Maneuvers only, we get an increase in performance. And when we combine maneuvers and gaze, we get better scores. But again, these scores are not as good as the previous one we saw here, right? Here we were seeing something between like the 80s and 90s. But here we see something in the 70s, 50s, 40s. But we are using totally different surgical procedures. We are training a model on curvatrectomy, validating on curvatrectomy. But when we want to classify surgeons, we are asking them to perform a phacoemulsification task in the simulator. And the model still performs relatively well. I mean, the model can still learn features that can classify the level of experience of a surgeon performing a totally different surgical task. And the opposite is also true. We had a model trained and validated on phacoemulsification. And this model performed well, for example, trying to identify the level of experience of a surgeon performed curvatrectomy. So this might indicate, again, that some of the learning of the model can be transferable not only across different tasks of the same surgical procedure, as we did with vitreoretinal surgery, but also across different tasks from different surgical procedures. And some conclusions of this project, again, there are behavioral difference between surgeons, and these standardized tasks on surgical simulator reveal them. Temporal deep learning neural networks can be used for experience, expertise, classification. When we employ multimodal data, it empowers automation via these models. We get better accuracy when we increase the data modalities being used here. Experience and skill assessment, again, is transferable between surgical tasks, between surgical procedures, and specific surgical tasks may better demonstrate surgeon's experience. We got better scores when we were using a model trained on membrane peeling, for example. So membrane peeling, some surgeons consider as one of the most delicate, complex surgical phase during vitrectomy surgery. And these, again, might be more representative of surgeon skills. So just a summary of contributions. I'm running out of time here. But with these four main works, we have developed a platform for real-time surgical comprehension in vitrectomy surgery that can be expanded to other surgical fields. We also investigated and quantified surgeons' behavior via metrics or performance indicators that can be employed, hopefully in the future, in novel surgical training methods or methodologies. We also developed a model for the automation of surgeons' experience assessment without human interference. So no surgeon, no attending was there selecting what are the most prominent surgical metrics to be used. And our platform is all open source and it's already available for the use for the research community. And our surgical database, as far as we acknowledge, it's the first comprehensive surgical database here in the US in an ophthalmic surgical center. For future research, I'm leaving here some points that I would like to do, and I think that's the future, the continuation of this work. The assessment of ophthalmic surgeons' learning curves, gathering more data, checking these learning curves, where they go, and see how can we apply this in novel surgical training methodologies. Mapping areas of visual attention in the OR, so going away from the surgical simulator and just surgeons watching videos, but we want to bring this to the OR. There's specialized hardware available for doing that. And again, what if we start applying all of this knowledge in novel training methods? Can these metrics affect training's performance? Can they improve surgical outcomes? And that's another point. We also want to cross-validate all of this with the surgical outcomes. For now, we are just considering the level of experience of a surgeon, but we should also pay attention on what's happening with the patient as an outcome of the procedure. And again, expansion of the comprehensive surgical database in ophthalmology. I think not only for these projects for surgical training, but for any other project that is related on the use of neural network for diagnosis, real-time surgical guidance, and so on. We need to start expanding our database, considering different recording devices, lighting conditions, and demographics in general, not only of patients, but also surgeons. These are the papers and the main conference derived from this work. Just as a reference, I'll be sharing the slides with all of you later. These are the general reference I've used during this presentation. Of course, I'd like to thank the committee members for all their patience, their guidance, and for all this work for the past almost 5 years. Some general acknowledgements, the AIO members that are here, and some of them are watching me on Zoom. All the faculty, in special Professor Luciano, who's here with us, since he was the one who put me in touch with Yannick and brought me back to Chicago. All the residents and fellows and faculty from the ophthalmology department who helped me during data acquisition and also setting up the experiments. All the staff, the HR, and so on. Intuitive, and I'm coming back to work with them soon. So I stole some of their ideas and applied here, I believe, kind of. And family and friends, of course. But if you have any questions, I think that's the time to ask them. And sorry for running 5 minutes over my time.
All right, the floor is open.
Is it possible to cross-train the neural networks with different procedures?
Yeah, so what we did was different tasks from the same procedures, and then different tasks from different procedures. So basically it was different procedures. So again, with a considerable drop in performance, but still.
But to follow up, why not have one master network that learned from all three of the procedures?
That's a good question. And this is something I should definitely have done, because some of these models, it takes, since we had like a limited amount of data, we were taking like 6 to 10 hours to train each model. So a comprehensive model, that would be really interesting. More interesting than that would be to start considering not only surgical procedures in ophthalmology, but why not? We have tons of data on robot-assisted surgery around there, like all the kinematics, X and Y position of instruments. So why not we just merge them, and we might have some really good, valuable data there.
You know, for the last aim, for the training, what's the training sample size?
For here? Oh, okay. So that's a good question. These tests, I don't have, in the manuscript, I should have the length of every single surgical task.
No, I mean, that's the number, it's out there.
Oh, yeah. You mean for the tasks we employed here?
Only 2, 3, 4, that's the sample number for the
Oh, no. So basically, these were the surgical tasks we asked the surgeons to perform. But every how many surgeons? Here we have 9 surgeons performing.
So how do you separate the training set and the testing set? Just for example, written only 2 subjects.
Oh yeah, so basically we had like those 10 seconds chunks of data, and we had like, we were shuffling the data, so the network could identify who was performing the task in that 10-second window. We were shuffling subjects, but not.
I think you want, maybe perhaps we can separate number of clinicians who created the data, the number of procedures or distinct videos, and then finally the number of 10-second frames that actually.
Oh, yeah.
So these
That's
are pretty important.
That's a really good information that I should put here, because yeah, every task took like 2 to 3 minutes, and
No, I
then
mean, my concern is the subject number.
Yeah,
I mean,
so
the subject number, because that means you can create that one sample sample from one opening.
Yeah.
But it's still from one subject, right?
I think.
They would be worth
Yeah.
it. So another concern, you know, only 2 residents, 3 fellow, even in clinical. Some resident, not necessarily bad kind of fellow, right?
Mhm.
Because only 2 or 3.
And it's actually something interesting here, because when you check the results, we always, most of the times we get better results when trying to classify experienced surgeons, attending surgeons, compared to residents. So for example, here with maneuvers only, since we have like a really low sample of residents, we will get like, here, for example, lower score with residents, but better scores with fellows and attendees. So that imbalance in subjects also shows here.
Yeah, I agree. In general, I agree. That's interesting. But my concern is that you trust, 2 or 3 subjects,
Uh-huh.
For
So
that people in training.
in maybe a different words, right? Like, did you create an attending like classifier or a Yannick classifier?
Oh,
Right.
yeah,
So, yeah.
that's good. And of course, the quickest way to solve this would be to expand the demographics and ask more surgeons to perform it. But I think it would be interesting to also think about different ways of splitting the data during the training, There are some techniques like the 5-fold cross-validation that I've implemented here, training this model since the data was limited, with different resampling of data every time I was training the model. But at the end of the day, still the demographics.
Anyway, in principle, one subject, we should count only one sample. Even you repeat one sometime, it still should be one. I mean, for deep learning training, otherwise it's biased, kind of heavily biased. Right.
That's
I
a
have
good point.
another question about your quantitative feature analysis.
Well, I'm not sure about that, Xinsheng, because if you consider different phases of a surgery as different tasks, you know, in a way, if a network is sort of classifying, you may have quite a bit of heterogeneous performance in between different phases, right? Just because, you know, especially among residents, there may be significant differences about how skillful or not they are in different areas. Not everyone achieves competency in every phase of a surgical procedure at an equal time point. So I think you make a great point that really you do need more subjects, you know, particularly among residents, because to your point and Rogerio's, maybe the reason that the resident classifier didn't work as well is if you happen to pick two very talented residents, they're going to appear more fellow-like or attending-like, and that's going to pose a challenge to the network. But I still think there is some value. I don't know that I would make the case that every phase is irrelevant, that only, you know, an increase in the number of subjects matters. You know, because if we extrapolate that, then we would say, oh, as long as you have a large number of subjects, you could even only have one particular phase or one task that you're using for classification. But I'm not sure that's right. I think there is still value even for an individual subject in having different,
You know, but
phases.
anyway, you assume, for example, one subject belongs to resident group or, you know, attending group. You already assume that's running the material and that's running the, in other words. So it doesn't matter how many procedures you involve, you already assume, you know, that's, you know, resident.
Sorry, that a resident what?
You already, you know, codify that. You assume, you know, the beginner is a beginner,
Yeah.
and the intermediate is a intermediate. It doesn't matter how many procedures you involve. Right, you assume, that's your assumption. That's also my concern, you know, some resident, maybe they have a better skill than, you know, fellow or attending. This might be happen because only a small number there.
Yeah.
Right.
Although I can tell you, I mean, and Raj has gotten at this as well in terms of the variable we've chosen. I mean, I've been doing this for 15 years and I've yet to meet the resident that is more skilled as a microsurgeon than the attending microsurgeon.
Yeah.
These are not things that translate from having played the piano or violin. So I'm not sure that that's a totally false assumption that residents, not just in general, but in most surgeons' experience, without exception, require training to become skilled. It does not translate from other domains like sports or other things. People just, you know, it's quite clear, you know, I think to human observers that these differences exist. What is less clear, what we're particularly bad at, is quantifying those differences, whether it's improvement in the trajectory of a learner's progress or quantifying objectively the difference between one trainee and another trainee at a given point in time. So I totally, again, I take your point that if you happen to choose some very qualified residents, it really need larger sample sizes to be effective and to be truly representative. But I'm not sure it's a totally flawed hypothesis or even assumption to say that residents are not going to be as, you know, as skilled at executing surgical maneuvers as, you know, people who have had years of formal surgical training.
Okay, great, thank you.
Okay, so like, maybe to like, you know, piggyback off of that though, like, so it is a really interesting point though, in the sense that you've created here a resident, fellow, and attending classifier. And we kind of already have that just by looking at, I don't know, the car the person might drive to come to the hospital, right? So like, we don't really need that. But what if you had infinite resources, what might you try to predict instead to actually be a better predictor of surgical skill rather than where they are in their training?
First, I mean, the thing that I had in mind with, I would say unsupervised methods first, just kind of answering to your question and making another question. Do you think unsupervised learning methods here would help mitigate, attenuate the problem of exactly what you said, like the model being kind of biased already towards a special group? specific group.
Yeah, but anyway, it's not matter what's the model you use. 2 or 3, I mean, for people anyway, that's a limitation.
Yeah, yeah.
We have to look at that, that's my only concern.
But now with unlimited research,
This is a good practice, I agree. But 2 or 3, sample, if you claim deep learning training. I don't know if people believe it. I agree, this is
No, yeah,
interesting work, but the 2 or 3 sample involved, that can be a limitation. We have to.
it's definitely the biggest limitation of this study. And answering Darwin, when I think about unlimited resources here, the first thing that comes to mind is like unlimited number of subjects to performing the test and unlimited data. Instead of classifying into 3 different groups, I would say trying to, like on the score base, although when we talk about scores with physicians and clinicians, that's not a good way to talk about the problem. But yeah, I would say like to have more granularity in the classification, or even trying to not give any labels and then see what
Wouldn't
happens.
it just be better to not its outcomes?
Yeah,
The certain
search for outcomes.
Is there a way now that is quantified that you can pull in that data?
We could, but right now it's a manual work. Let's say case by case, we need to check, go on Epic, and then read the surgeon's log. And then Dr. Dillon did like a great job between 2015 and 2019. He keeps like the log of every single surgery, and for some cases, like the surgical outcomes. So we have a little bit of data of that, but we should definitely, like, it's something that we should start now to be able to get significant results a few years from now. Considering the volume of cases performed here, do I see it's something totally feasible in the long term? Professor Luciano, and
Yes, I had a question.
Sorry.
I think Tom Royston mentioned about that. I mean, my question was in terms of how you can extrapolate the model that you created here to determine the relationship between the maneuvers and the gaze with the surgical outcomes for these fellows and residents and attendings, right? It's very impressive that the model is able to classify and determine if the residents, fellows, or attending. But the most interesting is that the fact that the same model can be used for different procedure, right? So you train with one procedure and then you test it with another one. So I was wondering how much you can extend the application of the model that you have trained to, other surgeries or other surgical procedures in ophthalmology, and how you can actually correlate that with the surgical outcomes.
Yeah, that's a great point. Since we started with phacoemulsification task, of course, there are other surgical tests in cataract. So I think the next step would be expanding to that and see if this still holds as true, if we can still generalize the model to perform, to classify surgeons' experience. And I think like the most important is like starting from the field of microsurgery, eye surgery, and then going and expanding to other surgical fields. I would say that, and again, this is the point I've mentioned before, merging this data with openly available data from previous studies on other surgical fields would be definitely the next step. And of course, why not start working with other models, right? Transformers-based models, for example. I think we should be able to check if probably this is not the only model that can work with this sort of data, since the original research that delivered this model was actually to identify human behavior, such as like someone walking, running, or jumping. And we were able to bring this back to the surgical field. So I think there's a big potential to expand to other surgical fields and still get like considerable results.
That's fantastic. Fantastic job.
Yeah, thank you.
That's another question. When you were setting up this, I guess this is the 4th topic here, you said, okay, before you were looking at all these different maneuvers and you had the mean and the whatever, standard deviation, comparing residents, fellows, attendings. And you said, well, okay, instead of that, we'll go to do this machine learning thing, where we're just gonna. Would another approach be to take all of these different, I guess these are standard statistical groups and just kind of do like a multi-parametric standard statistical analysis? And then I guess I would wonder, does that do just as well as your neural network?
Such as like a logistic regression with
Yeah.
all the variables. Yeah,
Right.
but since like some metrics showed like a statistical significance and so on, when I look at this, I was like, yeah, probably I can create a logistic regression model and fit all of this. It will classify perfectly. But I would say like the challenge was not that clear. I was like, yeah, I mean, for sure, a logistic regression with this data would definitely work. And that's why I was like, no, I just want to jump for an automated way. Because even though if I have a logistic regression here, the selection of metrics performed before was not automated. So there's still the bias. And I wanted to remove the human element, like of the surgeon selecting what metrics are important.
No, that's a fair answer. I wonder if it would be interesting though to compare how well.
Absolutely, yeah. It actually it shouldn't take too long. Yeah, it's a matter of feeding simple models and running.
It's the old-fashioned cluster analysis with or without PCA.
Yep.
I have one question for the filter. The bottom middle one, that feature is the distance from the toe tip to optic disc, right?
Yes, exactly.
Why that feature you think that's important? You know, my understanding is, you know, optic disc is a fixed location, but your, you know, surgical location not necessary to have a fixed distance there. That I have some confusion. How to understand that?
So we were able to select this metric when talking with some surgeons, and I also talked with Fiona about that. And it was observed that residents or fellows, I mean, since there's this general recommendation of the instrument never being closer to the optic disc, just to avoid any involuntary contact of the instrument to tip with the optic disc. So
I mean, if your surgical location is far away from there, why that is can be an important marker. I mean, it's depends on where the lesion you want to work on, right? Where is the surgical location? But if you know, you just happen the surgical location is close to the head, it's okay. But if you're far away, how to link them together? I have some feeling.
okay, I think the main goal is like when you analyze our entire procedure, although of course sometimes the surgeon needs to get closer to the optic disc and so on. When you look at the broader scene, if there's this tendency of novice surgeons going.
But you are qualified to teach and to design for them. I just don't understand the concept. If the surgical location is far away, why that is?
So the way that I see this, Chin Cheng, is that particularly really with relevance in this case to the core vitrectomy task. Surgical viewing, in some ways, in analogy to clinic-based static fundus photography, so-called wide field or ultra wide field photography, like the Optos, is not able to visualize the entirety of the vitreous cavity. It's a three-dimensional space. In general, it's about 4.5 cc's in volume, and to perform an effective core vitrectomy, you need to pass that instrument through the entirety of that space. And so one of the reasons I think that Raj chose this as a variable is that in order to be able to visualize the maximum volume, really in a two-dimensional image, it looks like area of the vitreous cavity, you need to be adept at using the microscope, and you need to be adept at using the tools at the very far periphery of the view. And so that's why in the beginning of training, and there's some intuitive underpinnings to this, trainees are not nearly as effective at wide angle visualization. They're also not as effective at actually maneuvering the instruments in the far periphery of the frame, meaning at a Cartesian distance in a two-dimensional image. far away from the optic disc. So that was our hypothesis, and I think that the data bears some of that out, that trainees tend to spend more of their time exclusively doing the vitrectomy in the area that is easier to visualize and probably also easier to navigate the instruments. And part of learning and skill involves becoming more effective at visualizing farther away from the disc and being able to get the instruments there.
Okay, I see. Yeah, that makes sense. So that's mean, if my understanding correct, that part that should be only involved for the searching procedure, not the surgical procedure. If for the surgical procedure, the surgical location can be very different.
Yeah.
Right?
Yeah, I mean, maybe to try and put it in a way that's more intuitive, you can imagine a core vitrectomy as trying to scoop formed vitreous out of a fishbowl, a three-dimensional space. And you need to travel the instrument everywhere in that space to remove as much of the vitreous.
Yeah, that's why I said, it's useful to use that command only for the searching
For,
procedure.
For the core
vitrectomy, yeah.
Don't pull out the surgical thing.
Yeah, for the core vitrectomy, because in every case, we pretty much have to remove all of the vitreous.
Yeah,
But not as much for things like membrane peeling.
and that's a really good point, because you can see that the only surgical phase where we identified a significant discrepancy was during core vitrectomy, not during membrane peeling, which makes sense because most of the times membrane peeling is occurring like around the macular hole, around the macula, and it's kind of like a fixed distance to the optic disc, so we wouldn't be able to differentiate this behavior of the instrument tooltip distance to the optic
Which
disc.
is exactly Dr. Yao's point,
Yeah.
right? That there should only be certain phases or tasks
Yeah.
where that Cartesian distance really makes a big difference.
And actually, this is another, this shows another limitation of this, because we were getting all these surgical tasks, but we weren't considering exactly what was being treated in every single surgical case. Of course, the core vitrectomy is kind of standardized, but more interesting would be to go deeper and check exactly what was every single surgical case treating.
So Raja, I have a two-part question for you. Dr. Hetling hit on this a little bit, and you did during your talk. For the performance indicators, we've discussed that all of these were pre-specified, right? Some of these come from surgical literature and performance assessment in other fields. Some of them, I think, like the one we just discussed in terms of Cartesian distance from the optic disc, are ones that come from sort of anecdotal surgical experience. But you talked a little bit about, the first part of the question is, how would you try and identify a priori parameters or variables, not once pre-specified by a physician? And the second part of that is, since you talked about how the whole goal here is not just assessing someone's performance and assigning a score, but having having that benefit improvement, what role is there for explainability, or not even explainability, even ability to implement, right? Like tool acceleration, is that something that really is learnable? So those are the two parts of the question. How would you do it in terms of identifying a priori parameters, and what's your thinking about how important it is that they're explainable?
I mean, of course, in this field of research, there's the tendency of just put neural networks on everything. So the first thing that comes to my mind is like having a network kind of trying to develop, understand, or give me some metrics. What are the values that we could investigate? Now I just need you, I'm sorry, maybe I didn't get your second part.
So the second part is, let's say we were to do, to Dr. Hetling's point, a clustering analysis, and we identified a number of parameters, some of which are not really intuitive to the learner. I don't know. So, you have a network that finds that one parameter that's really important is amount of time that the instrument spends on the left side of the scene in a particular locus. Does that really matter? It doesn't seem to correlate to achieving the surgical task. Does that still have value? How important is that as a potential parameter if you were identified by, by something like the clustering?
Got it. Yeah. So I think this also relates with the automation, because let's say we are able to identify that for some reason a specific instrument maneuver on the left side of the field of view is making a surgeon to be classified as a novice or as an experienced one. When we talk about this network here, the next step in explainability would be to basically extract what are the most prominent maneuvers, the most prominent pieces of time in which makes the model classify. And by default, by consequence, you would basically be able to identify what was happening in that specific point. And again, that could be identified as a metric if it's something consistent that happens every time. So instead of instrument tooltip acceleration, let's say we are able to identify that short 3 seconds of time, piece of time here is always displaying tremor. So basically we link with the original video source, and then it's like, okay, so this feature is classifying the surgeon as a novice. And every time the acceleration here is high, but you can see the tremor of the instrument. So I think that will be the next level of explainability. And I think that fits the second part of your question. Any other?
Even just with this data set, you could invent so many more parameters, or extract so many more parameters from what you have now, and maybe you use 9 performance indicators that did pretty well, but maybe there's some different set of 5 that do even better. I don't think you analyzed like the straightness of tool movement. You can start to analyze
linear,
path, things like that. There's quite a bit you can do with it.
A way to expand these metrics would be the ideal. Yeah, you can see sometimes when you're investigating, when you're working on some explainability methods for deep learning models, or machine learning in general. Sometimes you see but usually you have already your 20 or 30 different variables, and then you can just rank the score, like the impact score of every single one. But here we had to create the variables from scratch, and that was the most limiting thing.
Rogerio, I had a question, if that's all right. Can you hear me?
Sure. Yeah. Can you hear us?
Yes. So I was wondering, where do you think this body of research is going to go? So let's say that, this is great, amazing preliminary work that you've done showing that you can train models to look at gaze, look at the video, and understand possibly where they are in their training journey. But let's say that, this is all successful. You're able to do this with extraordinary precision. What's the next step that happens after that? After you use these tools to quantify somebody's surgical behavior, where do you think the technology here could be used downstream after you've solved that problem?
Sure. I think to start, it could be used as a complementary technology in surgical training, the same way that the IC right now is used, right? So the IC provides a score to the residents who goes there and perform some tasks. Now, the impact of that score, and this is something I would need to check with our ophthalmology department, is that is there a minimum score that residents need to achieve? If so, is that being considered in their surgical training? And then we can start from that. So basically as a side tool, or at least as a self-assessment tool to be used at the beginning. After that, and after conducting several studies showing the effectiveness of these solutions, then we can jump to more, let's say, serious things. So we start using this to be sure that we are able to mitigate some sort of bias in surgical assessment, and then start taking these values, these metrics, and these outputs as something reliable in surgical training. But there will be a lot of discussions on that for sure, because again, as something as I discussed it with you and Yannick, for some reason, I really think that when I show these metrics to a novice surgeon, I'll just see a novice surgeon moving the camera frenetically just to get a good score as an expert moving microscope camera. So it's something that also goes to the psychology field. In my opinion, it's something to wonder about.
Well, I guess a follow-on to my question then is, I guess, do you see this any application of these tools or this technology beyond surgical training?
Beyond surgical training. Okay, yes, because since we're working on real-time surgical feedback, real-time surgical guidance, if we are able to identify some specific surgical maneuvers that are representative of a novice surgeon or a harmful condition, we can also apply that for real-time assessment and providing feedback to the surgeon. Like this behavior of you, Mr. or Miss Surgeon, right now is harmful based on the database and on the models we have trained on previous procedures and previous surgical training. So I would say that would be totally like the next step, the ideal. Not sure if I have answered your question.
Oh yeah, no, you did. Great, thank you.
Thank you.
But I think to Aaron's point, if I understood your answer correctly, that will require, and Dr. Royston touched on this, that will really benefit from tying outcomes data, right? Because you're making the point that what's important is not necessarily warning someone that they're behaving trainee-like, particularly if we don't know that that's going to be associated with course outcomes. But the case that you made is that if you are training a network to recognize surgical behaviors that may be associated with adverse outcomes, whether that's performed by a trainee or to Aaron's point, an attending surgeon, that's where the utility is. We can't do that from this kind of data yet, but I think as multiple people have mentioned, the value of using outcomes data tied to surgery can potentially do that.
Oh, I agree. I think like this would be like the ideal scenario, considering the ideal model trained with like the most comprehensive data possible, also considered surgical outcomes. Then from there, we could start thinking about doing more concise interventions, even during the surgery and not only during surgical training.
You can make a real life operation board game. It was a little too fast.
Yeah. Maybe that's the future of surgery. I don't know.
I remember one time you mentioned, one particular application you put improvements complement. So you added clinicians, right?
Yeah, I mean, my sense of this is the entities from what I've heard that are most interested potentially in actually quantifying performance are certainly not surgeons. I mean, Dr. Lee can weigh in as well, but I have certainly heard that potentially healthcare administration arms of the federal government, like Medicare and CMS, and potentially insurers do have some interest in already certainly in surgical outcomes tied to individual surgeons, but potentially that could be extended to surgical performance of individual surgeons if you have some validated way to measure and grade that. Again, I think that's just some, Aaron, I don't know if you can weigh in on that. This is some speculation and things I've read in the literature as well. It's certainly not anything that I'm aware of being deployed even in other surgical areas outside of ophthalmology yet, but I have heard some potential interest there.
There's certainly been a lot of talk, and there's a lot of excitement about this. So I think this is just the beginning.
Great. Time for private questions.
Yeah, any other questions from non-committee members? All right, anybody who's not part of the committee?
And I'll
Welcome to leave, including people
on Zoom. Yep, I'll have to kick out some people here. Sorry. In the waiting room. Thank you all.
a little more oxygen for the rest of us in this
Yeah.
small.
All right. And am I allowed to record the private questions session? Or better to just stop?
I think you should stop.
Yeah, right, yeah, now comes
Yeah.
the real fun.